thank you, Peter, for that very kind introduction. Peter is a dear friend and colleague, and I very much appreciate the invitation from you and Michael to come. In addition, I have to say it's very humbling to be here because two of the mentors in my career have been your two preceding deans, both D.A. Henderson and Al, who today is in London and could not be here with us. As I told D.A. earlier, I take full responsibility for all the things I say wrong and all the things I say right. D.A. was very instructive in helping me understand those. With all seriousness, it's a real honor to be here again with you today and to share this. Also, I want to thank President Daniels for being here, a very busy college president who takes the time to come to an event like this. I think says a lot about the commitment of this organization, institution, and mindset in terms of dealing with this issue, and I thank you. And last but not least, I never forget about the fact that every time I give one of these talks or talk about it, I'm talking about real human people who are experiencing the most amazing tragedy. I, on an average, talk 2 to 3 times a day to colleagues in West Africa. And I had a conversation yesterday that was very painful where one of my colleagues, who upon leaving the treatment center, actually went down a street and saw 2 children both struggling by themselves, obviously quite ill, and nobody was there to help. And it was just heart-wrenching to hear a man who had just spent all of his time in a treatment center watching people die to have to then go out in the street and watch these 2 young children. We can never forget that at the heart of all of this, it's that. So to begin today, though, let me just start out by saying that I have no disclosures to make from a financial standpoint, okay? But I do have one major disclosure to make. I know a hell of a lot less about Ebola today than I did 6 months ago. And so you can take whatever I have to say in that light, because as I've learned more and have made a real effort to understand Ebola, our group right now is doing a major piece on the transmission of Ebola virus, and we've now reviewed over 900 papers published on Ebola. 700 of them in great detail, and I can tell you the more I learn, the less I know. So let me use that to set the tone for what my comments will really be about today. Daniel Bornstein, former librarian to Congress, once said, "The greatest obstacle to discovering the shape of the earth, the continents, and the oceans was not ignorance, but the illusion of knowledge." We'll talk about that today. The second thing, the great late Richard Feynman, Nobel Prize laureate in physics, once said, "For successful technology, reality must take precedence over public relations, for nature cannot be fooled." I would add a slight addition to that and say, in this case, for a successful public health response, reality must take precedence over public relations, for nature cannot be fooled. Today, that really sets the tone for my comments, in which I want to share with you. As Peter very kindly laid out, I have written a series of articles that over time I've even watched my own evolution from where I was back in July when I wrote that first piece to where I am today, and I'll try to share that with you. I don't consider having been wrong before, but I also am willing to understand that as we learn more, we may ultimately have a change in how we look at or understand what's happening in the world around us. As you noted, Peter, I've used often the concept of the black swan event. Taleb, as you know, an economist, actually described very nicely this metaphor of a black swan, a bird that once was thought not to exist, to explain financial events. His very well-publicized book in 2007 actually took that beyond finance and suggested black swans events were those which come at us with great surprise. They're typically catastrophic events, and they're ones that, when we look at, they often tend to happen quickly, which may be the first slight alteration from this event versus his description of black swan. But in retrospect, they are always ones that we rationalize, oftentimes irrationally, that we should have known about it and could have dealt with it. Well, I would also like to challenge that notion today, because I think we are about to see a whole rolling blackout of black swan events associated with this event. And I hope that we can prevent a number of them by actually anticipating them as opposed to waiting until they happen and then understand what happened and what we could have done about it. Imagine the storyline for the last 10 days in this country. If an individual who had come from West Africa to Dallas County, Texas, had been rapidly identified, had had a very effective and comprehensive response to the context in the community, and the healthcare worker evaluation situation was one where we did it right. We could have kept an extra 10 days our eye on the ball of West Africa, which is where this ball has to be. In retrospect, we can go back and figure out all the things that should have and could have and might have gone right had we done something different. Today, I hope in this presentation to share with you a sense of how do we lean forward, think about where tomorrow is, and to change tomorrow by doing something today, but only by actually taking a step back and asking ourselves where we're at. I think that's going to be a critical issue. So today, let me just say that I am of the notion that we have a lot of unexpecteds ahead of us. Come to expect the unexpected. Do not expect that anything carved in stone today will not be blown up by some scientific or intellectual piece of dynamite. It might be. And be prepared for that. That's a very different statement than saying we can do nothing, we know nothing, we are afraid that we can't respond. That is a very different statement. But it's also what I believe will sustain the credibility of who we are as a public health world. Now let's take a step back. One of the things that I find very concerning today is the amount of hubris we have about what we know about Ebola from the standpoint of what our history has been with Ebola virus. To date, there have been 24 outbreaks of Ebola virus infection in humans, and I use outbreaks loosely. 19 of those were really community outbreaks. 5 were those of 1 or 2 cases or a laboratory situation. In those 19 outbreaks, there have been roughly 2,400 cases of illness. That's in 40 years. If you look more specifically, the longest set of generations we can find strung together in any outbreak was in Kikwik, where we had 5 generations. 5. This virus has hardly pinged the human species until now. It's hardly pinged us. And yet we have this sense that we know so much about it. We know about the virus, and we know about what it does in people. And maybe we do. Maybe when we get done, we're going to find out, you know, those first 19, those 2,400 cases were just like the next one. Something's different today. And as Peter alluded to, I actually, in the title of my op-ed piece in late July in the Washington Post, said, the virus hasn't changed, Africa's changed. I'm talking about the urbanization, which we long anticipated was just a gas can waiting for a match to hit. But maybe it's not just completely that, and I'll come back to that. So in a sense, again, is this the same Ebola outbreak as the past? No, it's not. Is it the same virus in a different setting? It could be. But I'll share more with you in what I think about. Let's acknowledge one thing. We are making this up as we go. But that's not new to public health. We've done that in the past. That's not a bad thing. It's just we have to be mindful we're making it up as we go. And in doing that, we have to become more comfortable with uncertainty. I categorically reject the idea that you can't tell people you don't know because you're afraid you'll scare them. There is a complete literature on risk communication that says people are never frightened by if you tell them you don't know, but this is what I'm doing to learn, or this is something and it might be very scary. The literature shows that over and over again there are 2 things that will turn them to be very concerned, if not scared. One is if you tell them with certainty A, and then you tell them certainty B, and then A and B don't happen, or they happen in a way you didn't tell them. Then they wonder about your credibility. The second thing is if you get dueling banjos. If you get one person saying A, somebody else says, oh, you're going to scare people, don't say that, because it's not true. The literature supports that that's when people get concerned. So within that idea, let me just say one of the worst enemies we can have today is dogma. Dogma should be, at the first instance, the thing we jettison immediately. That's very different than staying behind the science. That's very different than knowing what we know and how we articulate it. But do not fall into the trap of dogma. And I see far too many people today doing that for the fact that they want to reassure the public about A, B, or C. That is the dangerous path. In the piece I wrote in Politico a little over a week and a half ago, I actually laid out what I said were really 3 plans: Plan A, Plan B, and Plan C. And I started out by saying we're failing miserably with Plan A. And Plan A was trying to stop Ebola dead in its tracks in the 3 affected countries using the techniques we had so well used for so many years and effectively used for so many years. And there were reasons for that. First of all, I want to point out that we did have one what I call miraculous save. I mean, it really was remarkable what happened in Nigeria with the one individual, a Minnesota resident, who traveled from Liberia to Lagos, was infected when he got off the plane, But if you look at the intensity of that effort, over 1,000 people followed up in someone who is part of a high socioeconomic status group, largely within the healthcare setting where the exposures occurred, the fact that they extinguished that was remarkable. I think that was a real testament to the Nigerians and to the CDC. But if that same person had landed in the slums of Lagos and had gone undetected for a couple of generations, that wouldn't have been the same situation at all. I'm convinced of that. So we do know that these things can work, but once you get into this setting, do they work? And you know, in my simple Iowa mind, the way I look at this, imagine you have this incredible distance swimmer who can go 4 miles an hour, hour after hour after hour, but you put him in a river that the current's going 6 miles an hour downstream, and you say swim upstream. Every hour on the hour, he or she is 2 miles farther downstream than when they started, the hour before. Yet they're going like the devil. The question is, do our methods work when you have such a situation as you have with no infrastructure, no available health care, etc.? So in terms of Plan A, we have to accept, first of all, the unpredictability of the epidemic. We're in uncharted waters over there. We don't know what will really work. We don't. And we just have to acknowledge that. Why? Because one day somebody's going to ask us, did what you told us you were going to do work? And we just have to be intellectually honest and say, we're trying our best. I still recommend it. I still say, you know, treatment beds are key. I still say that you ought to be trying everything you can, or even home infection control kits. Anything you can do. But let's not make promises that we know right now we can't answer, because then we are just contributing to the problem. I think I want to just point out, the first set of presentations were simply outstanding, but I want to particularly point out Josh's presentation. It was really very good. Because one of the areas we're hearing a lot of criticism right now is, wait a minute, you got the CDC saying 1.4 million cases by the middle of January for 2 countries, but the WHO saying 20,000 cases by middle November for 3 countries. How can you be so far off? Well, this is another one of those areas where hubris, and I say hubris not in an unkind way, could get us in trouble. My answer, which is really simple, is there's just going to be lots and lots and lots of cases and lots and lots and lots of deaths. We don't know what that number is going to be. And we just have to accept that fact. So nobody's right or wrong here. I mean, we don't know. The precision around these estimates are, in fact, big enough to drive an entire convoy through. We also have to understand that progress is painfully slow. In the piece in Political, I talked about the fact that the virus was operating on virus time, and all the rest of us were operating on bureaucracy or program time. And the virus was winning hands down, and it still is. I commend the U.S. government's response. No other country in the world has put forward the same response the U.S. has. The U.S. response has been woefully inadequate because it's up against virus time. When the president tells us 5 weeks ago that he's going to send 3,000 troops, and until last weekend there were only 200 troops on the ground, now there's 300 troops on the ground. For logistical support, that's not 3,000. These beautiful slides showing all the donations that have been made, they're not there. It's not happening. And nobody's to blame, everybody is to blame, because the world was not prepared to respond in virus time to a crisis like this. Isn't it rather ironic that the only nation in the world that actually has an operating medical center right now staffed with experts in the medical area is Cuba? The only country in the world that has an operating medical facility right now in the 3 affected countries is Cuba, and they're actually doing remarkable work. Where are the rest of us? I know we're coming, and coming is important in the sense that it's down the road. But this is something that's operating in a very different situation. Imagine if the city of Minneapolis, having a large fire in downtown Minneapolis, had to call the New York City Fire Department to come as backup. There'd be helicopters showing the caravan of trucks going down Interstate 80. It'd be wonderful. But in the meantime, Minneapolis would burn down. That's what we have to understand is the New World Order when it comes to infectious diseases. We have to understand that the health system in these 3 countries has collapsed completely. By my best calculation, we still have had many, many more deaths in those 3 affected countries today from HIV, from TB, from the major measles outbreak right now, from pregnant women delivering their children under the most terrible of conditions, et cetera, et cetera, et cetera. From a humanitarian standpoint, that is a tragedy that's not even being reported on right now. And that is as desperate as it could imagine, because there is no other health care of any kind. And that, to me, is also another storyline that talks about what happens when you have these failed state situations and we have what's going on. The health system collapse has been incredible. So don't talk about just going over to build up Ebola treatment center beds. We got to talk about an entire healthcare system if we're going to really impact even Ebola. It's going to be very important. And again, I come back to the fact, and I want to leave no lack of clarity here. I believe the only thing we can do today is continue to try the treatment bed approach, to try to do as much as we can to isolate infected individuals and quarantine and so forth. But I'm ready to acknowledge, you know, I'm swimming 4 miles an hour, but the current's 6 miles an hour. It's not going to be enough. And let's not fool ourselves and don't tell the world it's going to be enough. But we've got to do what we can. It's just like with Dallas. It's now time for us to reconsider our response. You heard yesterday how federal agencies are willing to now reconsider their response. You know what? We should be able to do that and not feel like we screwed up. We should be able to do that and not feel like we're to blame. And yet we accept the media's accusations that, in fact, we screwed up. And I got to tell you, there's a lot of the public that thinks we have, because we're not willing to get our message out to say uncertainty is a reality. I am not afraid to say I don't know. I'm not afraid to speculate what might happen. But I always come back to what are the data? What are the data? We need to do more of that. Plan B. This was the part in my article in Politico where I said, wake up, world, we don't get it. You know, when it's over there in West Africa, it's kind of easy just to call it West Africa. Now, when you live in a place like the Bloomberg School of Public Health, where international health is such a prominent, important part of that, that's not true, and I commend you all for that. But in a lot of the world, you know, West Africa is there. They can't quite tell you if ISIS is in East Africa or West Africa or whatever, but they're all problems. And we, however, have to understand what is very likely to happen, and this, to me, is the next black swan waiting to occur. And this was very troubling to me when I did this. I actually published in the Politico piece a very well-known part, and I know we have individuals from the affected countries here today who I welcome them to speak to this. But every summer, our summer months of August, September, and October, a number of young men and boys basically come home to West Africa to help harvest the crops. Well established, much like the migrant workers here in this country. And in early to mid-October, they leave to go back east to work in the cocoa plantations, in the gold mines, the illegal charcoal operations, even in some cases fishing. And I wrote about this in the Politico piece, and several media sources actually questioned me about it and went to start find out on their own, and sure enough, their sources in Africa confirmed this was happening. These people move by basically the back places that nobody knows. There's no checkpoints. There's no identification cards. And what was disturbing to me is I actually had people from various governments call me and ask me where I got this information. Well, I just got it from talking to the people, the anthropologists, the sociologists, the people who have spent a lot of time trying to understand this whole issue in West Africa and have years and years. And one of the things I think that I've learned as much from any has been the anthropologists and sociologists. I mean, it's been a crash course and a very valuable one. But what does that mean? Well, if we're worried about this infectious disease forest fire in Africa burning away and the sparks flying occasionally into Dallas or wherever, imagine what that wind is drifting to the east right now. I don't know how it won't get into those other countries. And I can show you the routes that we know where these people move who are just jobs, and this is not other movement, just trying to get out of the affected countries. Literally, Lagos is a 1.5-day trip for these people. Even Kinshasa is not that far. Do you know that there are more people living in the slums of Kinshasa than live in all the slums of the 3 countries combined? If West Africa was a can of gas waiting for a match to hit it, the rest of Central Africa is a tanker truck waiting for a match to hit it. And we don't quite get that yet. And there is no plan B. There is no plan B. How would we fight this if, in fact, this were to suddenly flare up in one of these cities along the belt in equatorial Africa? What would we do? Could we fight it on 2 fronts? We can't fight it on 1 front. And all I'm asking for is not to divert anything from West Africa, but somebody better be thinking about a plan B. Where is it? I'll come back to this in a minute, but it's not just about Ebola. I've done several briefings on the Hill for some of the Senate and House leadership, and the people who had the most interest beyond the immediate health group was the intelligence committees, because they see if you destabilize this part of Africa, the whole terrorist issue is remarkable. I mean, we're already concerned about the breeding ground for terrorists right through to Eastern Africa. So, as much as this is a humanitarian effort, and it is, let's make no mistake about that, this is a self-interest effort too. I mean, if we were ever going to invest in a timely and a major way, we'd invest for that reason alone. We do not want to give the world another place where the states are so failed that you can go without impunity in terms of issues around terrorism, planning, location, etc. It's huge. I'll also talk briefly about another Plan B, but I'll do that in a moment, that some were concerned about because I did mention about other modes of transmission. I don't want that to be a focus here, but an important one. So what's Plan C? Plan C for me is one that I think is the only hope we really have, and that's vaccine. I'm convinced of it. I believe this will be an endemic disease. I think we will see peaks and troughs, and we have to be careful about the peaks and troughs. I've worked very closely with MSF over the past few months, and again, an organization that if anybody could win a second Nobel Prize, they should. And they have seen themselves this flash of cases, elimination of cases, shut down the clinic move, flash of cases, bring it back, shut it down, flash of cases, bring it back. We don't really understand what's going on in all that area. That's a huge piece. So to me, at this point, one of the things that we really have to understand here is that we don't understand what's going on within all of that, and that's why I think this is going to be an endemic situation and vaccine will be the answer. Now, having said that, I've got grave concerns about the vaccine situation right now. I think we've got great candidate vaccines. At least I was, some might say, brain dead to talk about something I've talked about with Ebola. I've been brain dead for decades, as some of you know. And I got in deep trouble back in the 1980s when Bob Gallo and others made the comment that they would have an AIDS vaccine within several years. And I was quoted in the New York Times that same week saying, I didn't understand how that could happen. I did not believe we'd have an effective AIDS vaccine in my lifetime. I just could not get my arms around how a retrovirus vaccine was going to work, okay? And, it's kind of like a beam-me-up Scotty machine. And I was welcoming the chance to be wrong. Well, I sit here today and say, show me the AIDS vaccine. I mean, I still have that beam-me-up Scotty machine issue. I do believe we can have an effective Ebola vaccine. I am convinced of that. I really believe we can. But there's a big disconnect between the work to get us there, the time it takes to get us there, and then getting it into somebody in Africa. And what we're not doing right now, we are not basically gaming this all the time, all the way through. When we're talking about a $57 million investment in the United States, that sounds like a lot of money, and I thank the United States for that. That's a drop in the bucket if we're really interested in moving vaccine. And in this regard, actually, we need to be dealing with everything at the same time. The R&D, the potential for measuring how it's going to work, whether it's vaccine effectiveness, efficacy, however, how are we going to make it, where are we going to make it, how are we going to do finish and fill, how are we going to actually get it to Africa, will it need a cold chain, how will that be sustained, who's going to get it into the Africans? I want to know that now. I don't want to do it sequentially and wait till we get A done, then we'll work on B, then we'll work on C. We need to imagine that tomorrow Kinshasa could be on fire. That means now. Jeremy Farrar at the Wellcome Trust and I announced yesterday we'll be co-chairing a Team B, sponsored by both CIDRAP, my organization, and as well as the Wellcome Trust, in which we're bringing together a group of the world's experts in each of those areas. And we're going to be coming out with a document within 30 to 60 days laying out the challenges that must be met to get us an effective vaccine. It cannot be business as usual. That doesn't mean you take shortcuts that potentially impact negatively in people's lives, but you don't wait for program time to catch up to virus time, because it never will happen. So to me, that's a very important part of it. The other part of it is we urgently need an international research agenda. We have none. We have none. I understand in a time of dire humanitarian straits, it's hard to do research. But we're not doing research for research's sake. We're doing research for prevention, because we have lots of major questions we got to get answered, and we don't know. I think it is a travesty. We are now into this outbreak this far, and we have a single set of viral isolates with genomic data from one location in Sierra Leone from May. And we got people making pronouncements about what this virus is doing. They don't know what the hell they're talking about. We don't know what's going on. We need to have that kind of agenda right now. We need to understand transmission better. What is happening there? Why is this different? Is it just the population, or are there other things going on? And I don't know that there is, and I surely don't want people to walk away saying, oh, that's scary, but we have an obligation as scientists not to have another black swan event. Ask ourselves what's happening and why. We need much more data in clinical virology. We don't understand that. I see evolutionary biologists and bioinformatics people commenting all the time about what's happening there, and we don't have a clue. We're looking in the most fogged up set of binoculars I've ever seen. We need data on clinical outcomes. I think today you saw some very good information here. I think Tricia's presentation was quite outstanding in terms of looking at these issues. What does make a difference? Is this a classic cytokine storm that we've seen with so many other conditions? What can we do about that? Can we? Right now, their MSF has one approach that they've taken in Liberia because of the dire conditions which they're delivering care, helping to understand how well that works versus a more intensive care method is true. And finally, the issue on risk communication. I just have to say right now, we have to do a better job. I think we've had a number of key people in this government who have tried very hard to do a good job, and I think they have. But we have a problem with the fact that we think we're going to scare people, and so we're always couching things in certainty for which certainty does not exist. And we have to start being honest about that. That is different than being scary. We don't really understand issues. If you saw Sunday's LA Times, you saw David Willman's piece in there on fever. Now, the WHO report that was in the New England Journal said 87% of cases had a fever in their case series, but there was a problem with that in a little bit because you had to have fever to be part of a case definition or be found positive in addition. So there was a certain self-selection. I mean, I'm not saying how big it was, maybe it was minimal, but it was there. I have personally heard from clinicians with a whole series of cases where people did not ever present through the entire time from the admission to the treatment center until they died that ever had a documented 101.5 fever. They never did. Well, now we have focused so heavily on fever for screening in our clinics and so forth. What if somebody presents and doesn't have a fever? What happens then when the media gets all over that and said, you told us there would be a fever, and you told us that, but now this patient's been found to really have Ebola but didn't have a fever. You didn't know what you were talking about. Now is the time to anticipate that and say, you know, most patients clearly are going to have a fever. We show that. But we don't know about this group, and we're trying to learn more about it. Tell them what you might have happen, and that's how you're going to, number one, learn about it and not feel like you can't talk about it. And two, then when it happens, if it happens, and I believe it will happen, you don't have to feel like somehow you didn't tell them the complete truth. The issue around airborne, I just want to cover, this is one briefly, I just want to say two comments about this. One is, please understand we're talking about two different issues here. Airborne in the immediate patient space. And there's been a series of things written about this recently where I got to tell you that we really have never been in a position to judge whether airborne transmission could happen because it's always been overwhelmed by the close contact transmission that's there. But aerosols are created. I've worked up too many outbreaks of norovirus infection where somebody like me was at the podium vomited and I nailed the first 7 rows here over the next 48 hours with norovirus, okay? Even though no one ever touched the vomit. We've seen far too many things like that. We don't completely understand. Even the case in Dallas. I'm not here to speculate because I don't know what happened there, and I've urged people not to speculate. But do we know that there was potentially any issue because its focus is now on intubation? So there may be in that close space a very limited hit kind of thing. But to say it doesn't happen begs the question of we should really try to understand that. It was never something we could do before. Epidemiologically we did, but we never could quite study it. We need to look at that. The second part of it, though, let me just say that, you know, I raised the issue about the potential for airborne transmission being more of a respiratory transmitted agent. And this, I think, I'm bringing it up today as more of a classic example of what we shouldn't do. I raise that because I've been talking to a number of Ebola virologists who are very concerned about it. And they were concerned about it. That made me concerned about it, okay? And some of them have spoken out. They've been cited in the media recently talking about it. And it's not this great evolutionary, we're going to have the mutation that's going to happen. And let me just tell you how some people have taken this. This was in the New York Times this week, from Carl Zimmer, nonetheless, somebody who most people would say is a very noted science writer. And he said, the chances of an American getting Ebola are tiny. And while viruses are known for mutating, Ebola itself is very unlikely to change so much that it could go from being fluid-borne to airborne. That's just fear. That's like saying you're afraid of wolves and you're really worried that one day wolves are going to be born with wings, they're going to fly around and attack people, and they'll fly from Montana to New York. That's just not a realistic worry. Evolution doesn't work that way. Well, you know what? I was one of those people early on explaining why HIV was never going to be a respiratory pathogen, because we understood the physiology of the lung, we understood which cells the virus was in, and we understood that that was not going to be an issue. That's different than this. Number one, we've had examples with subhuman primates where transmission of the Ebola virus has occurred via the respiratory tract. We had one where pigs transmitted to subhuman primates, and it was interesting because one of the bioinformatics people who commented a lot on this actually said, well, see, that's not a problem because they think it was just from cleaning up the litter on the floor that did it, which is even worse if they had thought through it. The virus actually was deposited in the floor and re-aerosolized with the litter. I mean, that even is worse, okay? But I think the point being here is that some people are concerned because we don't understand why that virus passed the first time in these subhuman primates. Today I've been given permission, something I've known about for a few weeks. When I wrote the piece, I knew about this and it's concerned me greatly. Gary Kobinger and colleagues at Winnipeg, the Canadian National Lab, actually took one of the strains from Guinea and put it into macaques a little over a month and a half ago. What they saw was remarkable. It was unlike any of the Ebola viruses they've seen in monkeys. It was much, much more severe. The pathology in the lungs was remarkable. And as Gary said, who is one of the most prominent Ebola virologists in the world, said, it is very worrisome to me about what I saw there. Maybe this is a different virus. Maybe there is that possibility, because you have that much virus in the lungs, maybe somebody might cough it up, and maybe you might get a cycle. Now, I'm not saying that here to scare people. Plan B. What the hell are we going to do if we suddenly see the potential for transmission that might be respiratory in nature? Do we have a plan? I don't know if it's a 1 in a million chance. I don't know if it's a 1 in 100,000. But the point of it is, if we can't talk about that because people say you're scaring people, and you know the blowback has been substantial. You know, I guess I'm getting old. It doesn't bother me so much anymore, because it was all based on what I believe to be the true science, and it wasn't an attempt to scare. It was an attempt to have people think about this. What if we had another black swan event, where now we really had a reason to be concerned about airplanes? I don't know what that chance is, but I want somebody to be thinking about it. I want a plan. And it's not based on just idle speculation. So let me just conclude by saying we all want certainty in this situation. I guarantee you we will not get it. Mother Nature will not allow us that. We got to stop providing certainty. We can still provide good science, we can still provide very effective public health messages, and we can still be in control of our own destiny as it relates to how we respond. But the virus is in control right now of what's happening. We have to understand that. Let me conclude on two final comments, both very, very important people in my life in terms of being a kid from Iowa. One was Lewis Carroll. He once said, if you don't know where you're going, any road will get you there. And I worry today, do we really know what the roadmap is here? The WHO has given us one, but that's almost already been thrown out. We need a global response that addresses this uncertainty that we have and does it in a very timely way. We cannot accept any more pledges. We can't accept donations. We can't accept numbers. We need action, and that's different. Finally, probably one of the wiser sages of all times once said, are these the shadows of things that will be, or are they the shadows that may be only? Ebenezer Scrooge. Thank you.